So, for the next few minutes, we'll talk about the more common opportunistic infections in HIV. Next. This is opportunistic to, and I think everybody really should know about it kasi minsan your patients will come with just these symptoms and not really diagnosed yet to have HIV. Kung alam na natin na they have HIV, it's very, very easy to diagnose these opportunistic infections. But sometimes, out of the blue, maybe walk-in sa clinic nyo, merong dadating, di pa sila confirmed to have the infection. So from having this HIV, which in your screen shows the ways of transmission. Next please. After the HIV enters the system of the patient, we believe that, that the HIV virus very simplistically leads to the destruction of CD4 cells. Okay. And over time, I show this to my patients na over time, if we do not do anything, the natural history of HIV will be continuous decline of CD4 cells. It's estimated that the decline is anywhere from 50 to 100 a year. So kung mag-start siya na normal CD4 uninfected, and then he continues to live on with hardly any symptoms of HIV, over time, pwede mag-decline yan from, let's say, 600 down to 650 to 600. And after several years, like siguro, let's say, 6 years, bababa na rin yun to less than 200. Okay? Next. So the next slide will show you the natural history of HIV infection. Look at the dark on the solid dots, no? That represents your CD4 cells. CD4 cells are really very specific, no? So dinidescribe siya ng many, when we talk to our patients, sinasabi natin, siya kasi yung general ng army ng immune system natin. And you can also give that description to your patients so that they really understand how important these CD4 cells are. Without treatment, there is continuous decline as you see in this graph. And over time, when it reaches the critical number of 200, I'm sure you know that, nagsa-start na yung opportunistic diseases, no? So, we see that in the graph. Next. Again, kung wala tayong gawin, the CD4 will continue to almost become zero and will lead to death. Okay, next. So ito, parang ina-outline na actually, we can map out depending on the CD4 cells of your patient. Kunyari, na-diagnose na, the next step is to get the CD4. You can actually almost anticipate what the probable opportunistic infections can happen to your patient, again, without treatment. Okay, next. So nice to have like an idea of this graph in your brain while you're talking to your patients. Some overall thoughts about opportunistic infections. They're really, tawag natin sa kanila OIs. They're really a group of from various etiologies, pwedeng virus, bacteria, fungi, protozoans, helminths, and even other life forms. No? Because your patients are immunocompromised, OIs tend to be more severe and disseminated. So yung, let's say, TB, pwedeng TB hindi masyadong severe sa otherwise healthy person, pero pag sa HIV patients, especially kung very low in CD4, it can be very, very severe at disseminated. Usually, some infections may have to be treated for longer periods of time and usually associated with specific CD4 counts. Next. So, pinapakita dun sa next slide yung ginawa ng PSMID Yan. So, pinapakita ko rin po dito. There's an actual book that just came out in 2016. It's very relevant. And I suggest actually na each of our hubs and each of us, kung pwede, have a copy of this kasi it's a very valuable resource that's there. Philippine experience, yan yung table of contents. So, almost everything that we need to know, especially kasi ang start ng treatment when your patients come in, when their CD4s are very low, that's when many possible OIs can happen. You really need this assistance, okay? So, I think Dr. Kate will help you with that. Tama, Kate?
Oo, hingi
Okay,
ako
next.
at ipapadala ko yan.
Okay. Alright. So again, this one shows na depending on what your CD4 counts are, parang nalalaman talaga nung organisms, no? So these various organisms can manifest itself, no, in specific periods of time in the immunocompromised state. Ngayon, yung OIs din, hindi rin siya exclusive for HIV patients. So, immunocompromised states like post-chemo or febrile neutropenia, yung mga ganyang patients, can also manifest with the OIs that we see in HIV patients. Okay, next. Okay, this one I borrowed from the data of Dr. Edsel Salvania. And they looked at the top 9, 1 to 9 kasi yung listahan of the more common OIs seen in the clinic of the PGH. No? So we see here na halos back neck to neck yung PTB, no? Pulmonary tuberculosis and PCP takes on most of the bulk of the infections. And then the rest are also TB, various kinds of TB, oral thrush, CMV or cytomegalovirus infections. Cryptococcal meningitis is number 7. Candidiasis na esophageal is number 8 and toxoplasmosis is number 9. So, us being physicians in the hubs, dapat medyo alam natin to. Okay. All right. So, let's go to the case. So, that case present the 26-year-old patient. Hindi siya known to be HIV, no? But presented with cough. Go back time. These are some of the diagnostic clues kasi ano bang iisipin natin, no? So, make sure we sort of like go over the duration of symptoms kasi might give you an idea of what the etiology is. Presence of fever, kung absent, diba? Baka non-infectious yung cause ng cough. Even in HIV patients. Character of the phlegm, di ba, scanty, sabi, dry yung cough, so might make you think PCP or atypical pneumonia or viral pneumonia versus those kinds of pneumonias that tend to be very purulent or marami talagang phlegm. And of course, the types of chest x-rays. So, yun nga, this is an important clinical scenario kasi in various permutations of the severity of how your patient will present, pwede siya mag-walk-in sa clinic nyo na umpisa pa lang ng shortness of breath, yun. Mahirap pa lang umakyat ng hagdan. Yan, sasabihin niya, may konting ubo pero wala talagang phlegm. So, it's good to just, before they get to a very severe kind of pneumonia, it's also good to have a pickup of that at an early stage of cough and fever for patients suspected with HIV. So how do we approach patients with cough of this kind? No? So very good to be able to have access to a chest x-ray. And then, of course, you'll have to test his sputum or any kind of respiratory secretions, usually we send it for gram stain and culture because bacterial etiology is still up there as a possible cause of this cough. We'd like to send sputum for Gene Expert MTB. So I hope your hubs have access to Gene Expert tests. Minsan mahirap makakuha ng phlegm kasi nga dry cough. So have some mechanism whether in the clinic or in the hospital through the ER. Sometimes may network tayo na can induce sputum. Essentially, we have the patient inhale hypertonic saline to make them be able to cough secretions from the lungs talaga. Ayaw mo na mga laway-laway pag ganito. Mababa ang pick up. You have to really get deep secretions from the lungs. So we send this precious respiratory secretions for tests like PCP, PCR, or PCP antigen. Yung pa rin yung tawag, ano, PCP. At saka bronchoal or if very ill, tapos still not sure of the diagnosis, you can go ahead and pursue bronchoalveolar lavage studies and send them for the same test, bacterial cultures, TB tests, and PCP tests. Other labs that then can help you include CBC, test called LDH, di ba? And ABG. Kung walang ABG, at least a pulse oximeter. And with all of this, minsan nagmamadali ka kasi very sick na si patient. You might want to do CT scan of the chest. Is also recommended. Kung hindi nyo pa nakuha yung diagnosis sa first diagnostic tests. Next. Next, Kate. Okay. So, so, if, so syempre, nandyan na si patient sa harap nyo. Whether in your clinic or in the ER, you have to like start doing some therapeutic maneuvers already while we're waiting for the results of the diagnostic test that you sent. Okay, so even in the PSMID guidelines, we are advised to still immediately as much as possible for patients that sound like they have a pneumonia to still cover for bacterial community acquired pneumonia. And this could actually be life-saving. So start off with that after you get your cultures, wala pang results, yan, start na. If your suspicion for pneumocystis pneumonia is high enough, it's good to start with cotrimoxazole or the trimethoprim sulfa combination, which is the drug of choice for pneumocystis pneumonia. If you have hypoxemia like this patient, surely may hypoxemia siya kasi di na siya makalakad, sobrang short of breath. It's prudent to start them, or it's a must and life-saving again, to start them on steroids, whether tablet like prednisone or hydrocortisone kung hindi maka take ng oral meds. Regarding starting off with TB drugs like HRZE, it's the recommendation is you can wait, no? Hindi to emergency medicine. You can wait until there are more information for you. Kasi kakakita mo pa lang ng patient. Okay, next. So, patients with HIV or suspected to have HIV, when even if they come in very ill, minsan their x-rays may not look like how they manifest to you during the physical exam. So for example, with this particular x-ray, pwedeng normal, no? Parang sick na sick pero mukhang normal pa rin yung x-ray. Next. That's when you get x-rays like this, you might think mo meron talaga tong pneumonia, you might want to do CT scan of the chest. More often, we see some abnormalities in the X-ray. Wait lang, go back. So, the last X-ray shows us yung sinasabi nilang reticular infiltrates. So, these are usually diffuse, occupying the entire lung. Hindi normal yung picture ng parenchyma, you know something is wrong. So, yan yung picture ng interstitial lung. Okay, next.
Wait lang po. Yung ballpen po ay mawala. Ayan.
Marinig. Yan. Okay. Minsan naman, mukha talagang pneumonia, di ba? May mga infiltrates talaga dyan. Yan. Again, in HIV patients, especially if their CD4 counts are low, may not follow what we typically know. No? So, pwedeng pneumonia. Alam mo, abnormal lang yung x-ray. Pwedeng ganyan. Okay? So, may patchy infiltrates on the right. Meron rin some interstitial patterns on the left. Okay? Next. Okay. And this one, mas grabe na yung x-ray na to, diba? So, seems more compatible with what he is trying to describe na short of breath na ako, konting lakad lang. And that's because there are really alveolar infiltrates and also a mix of reticular pattern in all lung fields, including the apices. Okay? So you could imagine kahit when you see x-rays like this and on the background of a patient who may have possibly HIV, marami ka ng differential diagnosis. Okay. Next. All right. This is another on a more advanced stage of usually sasabihin ng radiology, ito interstitial pattern, reticular diffuse interstitial pattern or reticular infiltrates. Cannot rule out pulmonary congestion versus non-cardiac causes of pulmonary edema. Okay. Or ARDS na nga yung sinasabi ni Ketty dito sa tabi ko. Okay, next. Okay. Next, please. Oo. Tapos, yun. Minsan, we sometimes, ano ba tawag dun? We get stuck with the diagnosis kasi the x-ray looks not very abnormal, yet the patient looks very sick. So, for instances like that, you can send them for CT scan. And here you would see all this talagang we order high resolution CT scan and you see the severe patterns of involvement of all lung fields. No? Next. Okay, next. Dun sa next pictures, I can describe this. Okay. Yan. So, ano ba nakikita nyo dito? Saan ba naka-point yung mga arrows? What do these arrows tell us? 'Di ba? Pag nakita mo yan sa clinic, biglang bibigyan mo na siya ng mask, 'di ba? Kasi baka mga cavities, they represent cavities. And speaks more of a possible tuberculosis more than the PCP pneumonia we were thinking about earlier. Okay. When the lesions are more in the upper lung fields. Next. Ito, parang the doctor wasn't very convinced with what he saw in the x-ray, proceeded with the CT scan, and here we document the cavity again. Pero actually, baka hindi ka na kailangan mag-CT scan kasi kita mo na sa x-ray yung cavity and makes us think this is more TB than other types of pneumonia. Pero pwedeng mixed. Next. Okay. Alright. Nung panahon namin, ang ginagamit, AFB, sputum AFB. So, we were able to see the Mycobacteria, which is a main differential diagnosis in this kinds of presentation, coming in with cough of 4 weeks duration, very sick, no? And shortness of breath. Okay. Next. Pero the recommendation now is really to use a more sensitive test called the Gene Expert. So yun nga, kung wala pa sa facility nyo, try to get access to that. So pwede tayo mag-refer sa mga centers that have the Gene Expert. The sensitivity of the sputum smear is only about 30%. So, minsan, kitang-kita mo na yung cavity, hindi pa siya AFB positive. But the sensitivity of the gene expert test approaches 100% supposedly. And the turnaround time, plus the fact that it can test for rifampicin resistance, which is a major issue for HIV patients, the possibility of MDR-TB, makes it the test of choice for patients with cough that you are ruling out TB. Okay, next please. Okay. So, just a side note, yung HIV and TB talagang sobrang deadly. Next, paki-press Kate, sorry, na-animate ko pala to. Yan. So, HIV suppresses human immune system, TB suppresses the immune system also, and synergistically talaga, when they happen in together, the risk of death is very high. So the our pick up as their doctors and in the system should be able to try to be able to identify these cases and treat them as soon as we can. Okay. Next. Okay. So that's about a little bit about TB. So isa siya sa main differential natin. The next differential is the Pneumocystis Suribachi, or historically was known to be Pneumocystis carinii. It's a fungus. It was before was considered a protozoan. Galing siya sa environment. Supposedly, nahihinga natin siya. Kung i-test tayo for antibodies, maybe we have, but because if we do not have HIV, our immune system is supposedly strong enough that it doesn't affect us. But when your CD4 is less than 200, then it starts causing illness. No? So CD4 of less than 200 is very critical. It's important for us in the hubs to make sure that all our patients whose CD4s are hovering around 200 or less must be on prophylaxis. Okay? There's right now very, very rare na yung mga cases of Pneumocystis Suribachi infection that happens when patients are on prophylaxis. Very effective talaga yung co-tri prophylaxis. That it's almost unforgivable if we have our patients, if our patients get PCP pneumonia because we forgot to give them prophylaxis. Okay, so keep that always in some kind of checklist in your hubs. Next. Okay, so ito yung mga pwedeng mga stains ng cysts of pneumocystis. Cysts sila. Next. Or minsan we proceed with bronchoalveolar lavage. Next. Next, Kate. Hirap ba pakinggan? Sorry. Yan. So, we sometimes get cytologies, no? So, we can see the cysts present in the spaces. They don't live in the airway. They really live in the parenchyma. Kaya kailangan talaga yung sputum samples are really deep kind. So you get it like really from the kabuturan ng iyong baga. Oo, hindi pwedeng laway. You'll miss the diagnosis. So if you need to do a bronch, then go ahead and do the bronch. Next. Next slide. Okay. Okay. Alam nyo minsan, ang galing-galing na natin mag-diagnose, di ba, Ketty? So, when I'm sure you, papasok pa lang yung patient, minsan naamoy nyo na meron siguro tong PCP. So, while you're waiting for your diagnostic test, it's very prudent to start them on PCP treatment. Sometimes, yung next slide na tayo. Sometimes, nasa clinic, di ba? Na minsan gusto mo na talaga umpisahan, yes, you can go ahead and do it as long as you give your patient some advice. Pag ganito yung nangyari, proceed ka na sa ER. Yung patient sa case natin, parang dapat kung you hear about it, he calls you. Okay. If he calls you on the phone, sabihin mo, proceed ka na sa emergency room kasi very sick ka na. Okay. The drug of choice sa hospitals natin dito sa Pilipinas, most of the time, we only have oral cotrimoxazole forte. So, basta nakakainom yung patient, hindi siya nagsusuka, that's a reasonable and actually a good choice to start with. If you're lucky and you're in a facility with IV and your patient is very sick, pwede na siya mapunta sa ICU, possible intubation, then go for IV formulation. Ang dose ng oral ay 2 tablets 3 times a day for 21 days. For IV, it's 5 milligram per kilo, Q8 during the acute phase, and then you can shift to oral meds. Okay, about steroids, life-saving talaga yung steroids, no? We saw kanina yung pictures ng mga cysts. So, the reason for the steroids is because to give the patient an anti-inflammatory buffer while you're treating and trying to remove the cysts. Yung cysts, pagkabigay mo ng co-tri, this PCP, the cysts of the Pneumocystis Suribachi starts to burst. And there's a lot of all of these materials that come out of the individual cysts of this fungi. It starts flooding the lungs. Nag-a-attract siya ng mga all of the cytokines and interleukins into the lungs. And if you don't give steroids in a patient na very severe na yung kanyang PCP infection, you'll come back the next day with the patient already intubated. So, to counteract this, you have to keep in mind na pag medyo mukhang sick yung patient, hypoxemic, PO2 of less than 70 by ABG at room air, or clinically, mukha talaga siyang hypoxemic, hingal na hingal, then you give, ang recommendation is to give the first dose of your steroids, whether hydrocortisone if IV or prednisone as oral, mga few minutes to 1 hour before the first dose of your cotrimoxazole. And that will save your patient. Okay? Let's say, may allergy sa cotri, anong gagawin mo? So, pwede magbigay ng clindamycin at this dose, the one in your screen, plus Primaquine. Kung wala pang Primaquine, start na rin with clindamycin. Okay? Kung, di ba, usually, nire-recommend mag-G6PD tayo, ang tagal ng results. Start pa rin with Primaquine. The PISMID guidelines recommend start off with the lower dose of Primaquine, mga 15 milligram per day, while you're waiting for your G6PD results to come in. Okay? So, basta itong slide na to mahalaga kasi parang ako I work in the, well, here in PGH at saka also at the medical city, we see a lot of cases na parang dumaan na sa level 2 hospital or level 3 hospital. Completely na miss yung diagnosis of PCP. Tapos coming into us more ill, siguro, of course, more ill than maybe a week ago. So, sayang yung pagkakataon. Kailangan ma-diagnose natin. Wag natin ma-miss at saka makastart tayo ng tamang gamot. Minsan tama na yung gamot pero mali pa rin yung dose. So, 2 tablets 3 times a day siya for 21 days. And please, if the patient needs hydrocortisone or steroids in the form of prednisone, then please go ahead and do that. The first dose of prednisone is 40 milligrams twice a day for 5 days and then taper it off. Okay? I hope that's very, very, very clear. Next. Next slide. Okay. Yung cotrimoxazole parang sarap gamitin, 'di ba? When your patients are enrolled to the ARV treatment, 'di ba? If it's less than 200, nagsa-start na tayo ng co-tri. Pero remember, marami ring side effects yung cotrimoxazole. So just be aware of them and advise your patients na these things can happen and that we monitor them. Okay? Okay. So sometimes your patients are already in the hospital 5 days, tas hingal pa rin. Anong gagawin mo? Okay, next slide, please. Okay. So, yun, mga options natin. Kung hindi pa nakastart ng steroids, start steroids. Kung hindi pa nakabigay ng sputum, then please pursue that diagnosis. Kasi baka hindi PCP, baka others like TB. And then explain to the patient, kung sure kayo na tingin nyo talaga this is PCP, explain to the patient, you know, how realistic are the prognosis is na it takes time. Kaya 21 days yung treatment kasi sometimes they may really need to go home with home O2. So you arrange for that and then you have to just try to explain that this will get better in time. Tama ba? So yun, PCP is not like an overnight success. Even if you make the diagnosis, nakita mo na yun yung lumabas sa PCP, PCR, for example, that's what you have in your hospital, patients don't get better right away. Okay? It really takes a while. So, minsan, I've really also treated patients as an outpatient kasi I feel the patient looks responsible, meron siyang strong family support. Anyway, kung bibigay mo naman ay oral medicines like oral cotrimoxazole and oral prednisone, then talagang logistically pwede siyang pauwiin with good close follow-up. Yan. Minsan our patients don't have funds to be admitted to the hospital. So, pwede mo pa rin silang gamutin as an outpatient. Basta hindi sila masyadong sick at hindi sila magka-crash sa bahay. Or if that's a possibility, give them advice kung at this point, kailangan pumunta kayo sa ER or yan. Ganong klaseng close, good advice. Okay. Next, please. Okay. Ito again, I'd like to emphasize kasi with primary prophylaxis, 'di ba? We're into diagnosing patients already eh. So kung ma-diagnose mo na siya may HIV tapos nakita mo the CD4 count is less than 200, please dapat hindi siya mawala, hindi siya ma-lost to follow up, and the preferred therapy seen here in the box is really cotrimoxazole, 1 tablet once a day. It's not in the DOH free meds, but it's very reasonable. They all can have access to it. Meron pa ngang regimen dun sa alternative therapy 3 times a week. That's also okay. Kaya lang ang problem sa 3 times a week, ang hirap yung routine ng patient eh. Hindi niya maalala kung uminom na siya o hindi. So for me, parang to get it into the routine of the patient, which he might be taking for at the least siguro 6 months, maybe longer. Dapat parang mas maganda na yung A1 recommendation in this screen, which is 1 tab once a day. Next. Okay. Meron such a thing as discontinuation. Okay. So, kailan mo di-discontinue? So, pagka tumaas na yung CD4 on next check, the CD4s are already more than 200 for at least 3 months, then you can advise the patient to stop the co-tri. Okay. Next slide. Let's say this patient went home on, di ba, dinischarge mo na siya kasi 21 days. Kailangan nandun rin yun sa prescription nyo at saka sa home advice that after matapos yung 21 days of 2 tablets 3 times a day, that the patient understands that he should be on secondary prophylaxis to prevent the relapse or reoccurrence of this opportunistic infection. So keep them on 1 tab once a day until the CD4 count goes up. Next. Okay. Next. Ayan, okay. Next. Yung patient natin, parang nung in-examine nyo kanina sa ER, di ba marami rin siyang problems na iba. So, another opportunistic infection, which we usually see, no? Usually associated with CD4s of less than 200 or viral loads that are very high, is the oral candidiasis. Madali lang siya makita. Usually, tignan mo lang, may diagnosis ka na. However, some doctors or staff may have some doubts, kunyari, parang hindi ka sure what it is, then do a KOH stain. If esophageal candidiasis yon, beyond just the oral mucosa, then scoping upper endoscopy might be prudent. Okay. Sometimes because of overuse of fluconazole, there have been reports of resistance to fluconazole, then fungal cultures might also be necessary. The treatment is 100 to 200 milligrams once a day for 7 to 14 days. Okay, next. So, mga itsura niyan, pwedeng ganyan, di ba? Kita mo na kaagad. Or next. Ayan. Sobra yan talaga. Yan, hindi mo na kailangan i-KOH. Pwede mo na i-treat kaagad yan. No problem. Okay. Alright. The patient, our case kanina, also presented with diarrhea of 4 weeks. So this is another opportunistic infection. Again, kung meron kayong mga patient na nagwo-walk-in, young male or merong risk factors for possibility of HIV, then the diarrhea should make something alarm in your head and think about HIV. Okay, next. So, these are the very, very many causes of diarrhea among patients who have been confirmed or are suspected to have HIV. Ang pinaka-opportunistic dito ay yung nasa protozoal. Yan, yung Microspora, Cryptosporidium. Next, Kate, please. Pero marami talagang pwede. Okay? So, among the enteric pathogens, kasi syempre, pwede ring hindi necessarily opportunistic. Pwedeng may nakain siyang bad food, 'di ba? So, pwede talaga rin siya magka-diarrhea. Pero yung nandito sa circle, yung protozoans, normally, dapat hindi ito nagkakos ng major illness sa atin. But among patients whose CD4s are again low, they might cause opportunistic infections and present with diarrhea. Next. So, yung tests include all of these tests. Usually, high yield yung mga stool exams eh. So if you're lucky, maybe you don't really need to do anymore the endoscopy and the imaging kasi baka ma-pick up mo na with the just doing fecalysis or special stains like AFB stains, modified AFB stains to show the Cryptosporidium, Isospora, and all of that. Next. Okay. Merong published ways to okay. Merong published ways to yung algorithm ng diarrhea, no? So again, minsan nagtitipid tayo, So go for high yield tests, and the best tests are really related to the stool test. So go for all of those. Tapos pag hindi pa rin nakita, then that's the time you might want to refer to GI for endoscopy plus or minus biopsy. Very frustrating minsan yung workup sa diarrhea kasi minsan di mo mahanap tapos nagtatay yung patient, papayat siya ng papayat, di siya gumagaling kahit umiinom na siya ng maraming gamot. Plus, let's say like your patient, meron siyang PCP, so umiinom siya ng Cotri, baka hindi niya rin ma-absorb because of the presence of diarrhea. So we need to work this up also urgently. Okay, next. Okay. Dun sa mga opportunistic infections, you would see that sometimes like Cryptosporidium, wala talagang clear-cut treatment, no? So, after all that workup, sasabihin mo sa patient, well, sir, ang treatment talaga ay yung antiretroviral therapy. So, we do that. Okay? And then we follow depending on what you see in the stool tests. Okay? I inserted here another case, no, to just show how patients may present with other kinds of opportunistic infections. So this is similar to one of the cases that Kate read earlier. A 28-year-old man was brought to the ER after a witness seizure. His family members report that he had some memory loss and unusual behavior in the past 2 weeks. This patient is an English teacher. Hindi siya known to be HIV positive. When he came in, when you saw him, he's confused and disoriented and some weakness in the right side of his body. Next. Yan. So, pag-scan, yan na nga, parang hindi ka na maliligaw ng landas dito. You know that there is a encapsulated lesion, very large lesion in the brain. So it's a mass lesion. Okay, next. So we have to distinguish whether this is a brain abscess or a solid mass. Usually, madi-describe siya ng MRI or CT scan depending on what you had. Okay, so it can present in various ways. It can look like there's fluid inside, like this one. Merong capsule, tapos merong parang possible fluid inside, or they may appear as solid masses. Okay, next. You would see also na the brain is very edematous, no? Magang-maga. There's almost no sulci seen. So you could understand why parang for a long time, the patient was just having some headache. Tapos very acutely in the last 2 days, nagpresent siya with mental status change. Kasi sobrang naging edematous na, very possibly dangerous sa life ng patient yung amount of intracerebral pressure already in the brain. Okay? Next. Okay. So again, dun sa CNS mass lesions, may mga known algorithms na on how to proceed. There's like a long list, but the more common ones are toxoplasmosis, lymphoma, PML. Sa Pilipinas, hindi nawawala ang TB. So, panay part yan ng differential. Okay? So, usually you'll have some help from the scans, whether MRI or CT scan. Serology, you can only do so much. So, for example, sa toxo, you can only get a toxo IgG, which just tells you na once upon a time na exposed siya sa toxo, but won't tell you that that particular lesion is really toxo in nature. If some blood cultures are positive, that could also be helpful. But doing a CSF test, if that's possible, is going to be helpful. Pero again, the other side of that is there's a big lesion in the brain. Most people na mga neurologists or neurosurgeons would probably be brave enough to get a tap right away until you decompress the brain. Okay? So you might have to start off with some empiric therapies. Okay. Next po. So among these, toxoplasmosis is one of the big bets, especially kung mababa ang CD4. Toxoplasma, as we know it, really supposedly transmitted or carried by animals around us, especially yung mga cat owners. Yan. And the most common site of their manifestations in humans is really the brain. Pero may other sites involved. Next. Kailangan lang siya isipin, no? So, we think of it if the CD4 is less than 100. Some are able to really get a biopsy of the lesions and actually show all of these organisms, yung tinatawag na tachyzoids. But that's not also, again, usually possible. So, pagka-combination of a low CD4, that mass lesion in the scan, and then not on prophylaxis, on co-tri-prophylaxis and a positive toxo IgG, we go ahead and treat empirically already with co-trimoxazole. Next. Okay. So, pwedeng ganyan yung itsura kung we're able to get a sample of the brain tissue. Next. With the tachyzoids, yung malalaking parang multinucleated organisms. Next. Okay, again, another shot of the biopsy, no? In my lifetime, parang once pa lang ako naging successful in convincing the patient to have a biopsy. The rest are empiric treatment. And when we do empiric treatment, most of the time when there's a mass lesion like that, baka hindi toxoplasma lang yung iti-treat mo. You treat it also as a possible bacterial brain abscess or TB. So you end up really giving the patient a lot of medicines. Next. Okay, that's another picture. Next, please. Pag sobrang heavy yung load, ganyan. Ito yung mga suggested therapies. What we have in the Philippines is really clindamycin, pyrimethamine, plus wala nga tayong folinic acid. And cotrimoxazole yung ina-add natin sa therapy. Next po. Pero gumagaling yung mga patient natin kahit hindi perfect yung ating available treatment. Okay. So, as I said, usually kung na biopsy mo, stereotactic biopsy, you're able to make a single diagnosis. Pero more often than not, we're left with a situation wherein we need to treat all the possibilities, no? So, usually a combination of antibacterial agents for bacterial abscess, toxoplasma, plus TB, especially if there is presence of TB in other parts of the body. Okay. Sometimes, very occasionally, we also see cryptococcal infections manifesting this way, no? Pero cryptococcus usually more often present as meningitis. So parang ganun din yung history dun sa case natin, headache, tapos mental status change, behavioral change, high pressures on lumbar tap. But what you will see will be more towards a positive callus, yung cryptococcal antigens, or the growth of Cryptococcus neoformans on your fungal cultures. Okay. Usually, merong association with presence of birds around the environment, but not always. Sometimes wala talaga. So this is talagang opportunistic infection. Okay. The therapy is giving amphotericin B. Sa other countries, may flucytosine. Wala tayo dito. So, usually, amphotericin lang yung nabibigay natin. In less sick patients, we can get away with fluconazole. But most of the time, we start off with amphotericin. So, may intensive phase of treatment. Next. So, yung India ink, no? Yan yung itsura ng India ink. Makikita natin sa CSF studies. Next, please. Itong cryptococcal meningitis, hindi to nagagamot sa outpatient. Kailangan talaga sila ma-admit. Okay. Okay. Next. So, yun yung whole thing about HIV and presenting with headache and mental status change. This one naman, yung clinical case 3, parang baka siguro mga 10% of our patients sort of present this way, yung parang hindi masyadong malinaw, pero yan. Wait lang. Okay, next. Ito, tama to. 40-year-old male, HIV 3 years ago, but lost to follow-up. So, hindi nakainom ng ARVs. He now complains of headache for the last 2 months. Pero ngayon, may behavioral changes, fever, vomiting. He's lost 20 kilos, has no cough, and his CD4 is 200. So, dito, parang pag 200 kasi yung count, parang baka hindi na siya toxoplasma, di ba? Baka hindi na rin necessarily cryptococcal kasi medyo okay yung CD4 ka. Hindi siya okay na okay, pero not enough to cause really bad kinds of opportunistic infections. At saka yung 2 months na may headache, medyo matagal na yun eh. Kung cryptococcal to, medyo dapat na without treatment, baka he didn't make it anymore to this time. So, you think more of chronic causes of these kinds of headaches. Okay, next. 20 kilo weight loss, so parang 40 pounds na. Yung kalahati na yun ng katawan ni Ketty. So, on scan, usually, yun, again, go for tests that are high yield. So, get a scan right away, a brain scan. And you see here that there's hydrocephalus and, again, a lot of edema and some enhancement in the basal parts of the brain. Next. So, dito yung concept of extrapulmonary TB. If you remember the table I showed you kanina, parang ang number 1 OI natin ay PTB. Ang number 2 ay PCP at ang number 3 ay EPTB, extrapulmonary TB. So, it is said that as much as 40 to 80% of our HIV patients have had some kind of TB in their lives, no? Ang pinaka most common is lymph node involvement. So yung mga sari-saring adenitis, whether cervical adenitis or sometimes kung sa women pelvic TB, ano ba yan? GUTB, yan. Miliary CNS and cutaneous TB are more likely to present in HIV positive than in HIV negative. And of course, the possibility of multi-drug resistant TB is more for EPTB than in PTB, in HIV patients. Next. So, sa EPTB and in TB in general, CD4 counts can be any CD4 count. So, pwedeng mataas pa yung CD4, 300, 400. Pwedeng may TB siya. So, it's not CD4 specific unlike your other OIs. No? Sometimes we're not sure whether that's TB or not. We use the tuberculin skin test. Medyo makaluma rin to, pero ang cutoff ay 5 millimeters. Sometimes, again, we're in situations that we have the interferon gamma test, the IGRA or quantiferon. So, sometimes we're lucky, so yun, magpa-positive din. Many of our HIV patients are anergic, so minsan kahit na negative skin test, we still go ahead and make the diagnosis kasi yon clinically we feel this is true. So again, kung you have TB and you ruled out active TB, your patient should be on prophylaxis regardless of CD4. Okay, so the recommended prophy right now is INH 300 milligrams per day with vitamin B6, B complex to, times 6 months. This may change, pero for now, this is the recommendation in our country. Okay, next. Yun, may first line, tapos may second line. Second line are for people who have resistance, multi-drug resistance TB. Okay. Minsan we also adjust the first line drugs depending on the other things of the patient like renal and liver problems. Next. Okay. So yung next mga pictures lang ng sari-saring TB nating pwede makita. So yan yung POTS, no? Kibus ang tawag dyan. So, it manifests next, please, with actual, next, may picture pa dyan na isa, destruction talaga of the vertebral bodies. No? They like, the TB likes to, or POTS, like sa lower thoracic and lumbar spine areas. Although we've seen sa HIV, kasi nga, atypical manifestations, minsan cervical yung affected, so pwede pa rin. Minsan long bones ang affected. Okay, next. Oo. Ito yung adenitis, no? Next. Yan. Parang ganyan yung picture na pinakita. Pagka binayapsi, ganyan ang itsura. Madali to ma-diagnose. Pagkuha ka ng sample ng fluid, teeming with AFB bacilli ito. So, not difficult to diagnose. Next. Ayan, yung sari-saring itsura ng TB, GITB of the liver. This is a problem to treat kasi hepatotoxicity yung problem with the drugs. Okay, next. Ito naman, sometimes ang presentation niya ay shortness of breath. Okay. So, kala mo may pneumonia, pero parang walang pneumonia, pero actually, meron palang TB of the pericardium. We know that there is probable pericardial involvement kasi may calcification, no? Yung shadow ng X-ray ng heart, which is the pericardium or pericardial sac, has calcification. Yan. Okay. Next. So, next please. Pagka pinakita to sa patient, ng patient sa inyo, make him mabilib sa inyo by telling him, oh, you probably have TB. Kasi makikita yung calcification, dito sa ilalim. Meron din. Usually, big heart. Tapos, merong shadow of calcification. Okay, next. TB of the skin. So, minsan mahirap imaginein what this looks like. Pero, ito yung itsura niya. Sometimes it's a non-healing ulcer or really, vague lesions na won't go away despite many therapies. So, pag yung nasa right side, kailangan niya ng skin biopsy to prove that this is TB. Makakakita ng mga Langhans cells or multinucleated or sasabihin granulomatous lesions. Next. Okay. To me, one of the more severe manifestations of HIV and TB would be yung tinatawag na miliary TB. Usually, very sick sila. Minsan, papasok sila sa clinic mo, ganyan, tapos may dala silang x-ray, tapos ganyan ang itsura. Miliary TB, to start talaga ng anti-TB meds immediately. Pero after getting sputum samples, usually they would have some cough. Okay. Miliary kasi yung next slide dyan. We'll show yung miliary, millet seeds, no? So, if you do a CT scan, whether plain or high resolution, makikita mo talaga all of this minute amounts of dissemination of TB. So, disseminated TB is when there are two or more non-contiguous, hindi magkatabi. So, hindi siya lang tapos plural effusion. Usually, magkahiwalay sila. When there are two or more spots, it's called disseminated. And that's usually, di ba, dun na naman sa list natin, disseminated TB comes after extrapulmonary TB sa top OIs in the Philippines. Next. Okay. So, yung last few slides, ito, pag umabot na tayo dun sa CD4 na 100, isip na tayo ng things that might happen or have allow opportunistic organisms to penetrate the patient. So, nung before ARVs were used, so circa before 2000s, 1990s, no? Retinitis was very common, said to be affecting as much as 30% of patients. Pero itong colitis as a cause of diarrhea, pneumonitis as a cause of pneumonia that doesn't seem to get better is still happening right now. Kailangan natin rin ito ma-diagnose. So, pagkang CD4 counts ng ating patient ay very low, think that there's a possibility of CMV and screen your patients accordingly. Sa retinitis, ang tatanungin naman lang ay blurring of vision. And if there's any hint na there is such a complaint, then go for an ophtha exam. Okay? Next. In fact, kung less than 100, some of us will just make it routine protocol to send them to the ophtha for initial screening. Okay. CMV is not difficult to diagnose, pero medyo mahal siya kasi the serologies at itong mga CMV antigenemia are medyo mahal to do. No? It will cost several thousands of pesos. Tapos like yung CMV antigenemia is only used in some centers like NKTI dito. Okay? So, pero yung retinitis, kahit sinong ophtha or in your center, try to identify a retina expert who can do this. Okay? So, fluffy infiltrates na may hemorrhage sa loob. Next. Ang usually. Okay. Kung may usually CD4 of less than 50 or kung may previous OI, a higher CD4 might be the threshold. And in the background of a positive IgG. Okay? So, ophtha should see the patient. Ako, ang very vivid memory ko ng CMV, it pushes me to just do screening for all patients. Meron kasing isang na-transfer sa amin na patient that was seen in another hub na na-startan siya ng ARVs without a screen, pero medyo meron na siyang blurring of vision nun. Tapos hindi na-treat, syempre parang after na-start yung ARVs, nag-go completely blind siya. So, the rest of his life, naging blind na yung patient. Sobrang morbidity yun. So, let's try to avoid those situations. Okay? Next. Kasi makikita yan eh. So, ito, picture to care of our resident na nakuha niya. This is kung may HIV, usually merong mga fluffy cotton wool spots na talaga. And usually it's the ophtha person or ophtha specialist who would be able to differentiate between just HIV retinopathy. And next, please, yung retinopathy, retinitis from CMV infection. Supposedly, there's a lot of hemorrhage in a lesion, within a lesion that's fluffy and white, and a lot of edema. Okay. Meron na ngang fundus photo ngayon eh. So, pipicturean nila tapos isi-send nila sa'yo. Yan din is another photo. So, when this is clinically made, it's also enough. We don't need to do further testing. It's enough basis for starting your treatment for CMV. Okay, next. Yan yung other fundus photos. Okay. Wait lang. Yung at the next, at the back pala. Siniksik ko lang dito to kasi believe it or not, may TB of the eyes din. So, there is such a thing and here in PGH, meron talagang mga ophthalmologists who have made case series of TB infection in the eyes. Okay? So, ano rin to, specialist na sila lang ang merong parang kaya nila because they've seen enough of it. It's hard to diagnose kasi wala kang kukuning specimen sa mata eh, 'di ba? So, you just look at it and make the clinical diagnosis unless there are other parts of the body with TB. Okay, next. Okay. So the treatment is IV ganciclovir or oral valganciclovir. Okay. Yung Foscarnet kung meron, parang ini-import pa natin to. Okay. Okay. Again, medyo mahal tong mga gamot na to, but available in the Philippines. Okay. Next. Okay, the last part, 'di ba? Meron tayo pagka your CD4 count is less than 50 na, ito na yung kino-cover natin with prophylaxis. Okay? So we've gone from CD4 200, yan yung mga PCP. CD4 of 100, yan yung toxo and CMV. Ngayon, nandun tayo sa CD4 count of 50 or less. This is your atypical mycobacteria or mycobacteria other than TB. So they can cause a lot of NKTI yata man. Cause a lot of infections in various ways. Pwedeng lung infections, sinus infections, abscesses. Yan. Okay, next. So, yung MOTT, marami rin siyang species, pero the one that we believe is causing a lot of problems for patients whose CD4 counts are very, very low is the MAI or Mycobacterium Avium intracellular or the MAC na yung tawag sa kanya ngayon, Avium complex. Their sources are just around the environment. Tapos, medyo sick yung patient. Fever, weight loss, parang lahat nandyan, sick siya, hindi mo ma-figure out kasi nakamakuhang specimen. Fortunately, for some labs na kukulture out siya sa blood cultures, no? So, mycobacterial blood cultures are able to confirm your diagnosis. Okay, next. So, ito yung binibigyan natin ng prophylaxis. Maybe that's also another reason why we don't see patients with MAC infections anymore kasi we are able to give azithromycin. Patients stay with it kasi once a week lang natin binibigay yung gamot tapos na-afford ng patient. So, yan. That keeps them from having this kind of infection. Next. So the symptoms really require you to be high level of suspicion. Yan. But it needs the isolation of and the growth in culture of the MOTT. MOTT, in contrast with the tuberculosis, mas mabilis siya. In 2 weeks, may growth na dun sa culture. So, mas mabilis siya mag-grow and isolate. Next. Parang malapit na tayo matapos. Yay. These are the different regimens that could be used. Basically, it's a macrolide plus ethambutol ang backbone ng treatment, plus or minus other agents. Okay, next. Okay, so ito na yung mga summary slides ko. Yan. So, how they can present to our clinics, yan, depende on the organs involved. So, sa pulmonary, think PCP to TB and the usual pneumonia. Sa CNS, think crypto, CMV, toxo, TB. Sa GI, all of those parasites. Sa eyes, mainly CMV. Pag disseminated, think of TB or MOTT. Yan. Okay. And then the last slide, depende sa pathogen. Yon. When your patients are, next please. When your patients are very immunocompromised, pwede sila talaga saniba ng katakot-takot na iba-ibang pathogens. Pwede fungi, mycobacterial, viral, protozoal, or some bacterial. Okay? So that's it na, Ma'am Kate. Yay, natapos. I'm so happy.